Good evening and welcome to the Interstitial Cystitis Association webinar, Creating a Positive Patient-Provider Relationship, featuring ICA Board member Joy Selak and her healthcare provider, Selak and Overman. This webinar will focus on how to find effective supportive care and creating a positive patient-provider relationship. This educational webinar is presented to you by the Interstitial Cystitis Association. Joy was diagnosed with multiple chronic painful conditions starting in her 30s, including interstitial cystitis, fibromyalgia, mixed connective tissue disease, and trigeminal neuralgia. She eventually had to leave her career as an investment advisor and endured over 20 years of disabling illness. Now in her 60s, and after many treatment and surgical interventions, Joy is well enough to work part-time. With Dr. Selak and Overman, Joy is the co-author of 2 editions of the book, You Don't Look Sick, Living Well with Invisible Chronic Illness. Dr. Overman is retiring from his 35 years of rheumatology practice to focus on patient advocacy work. He is a professor at the University of Washington and started the Seattle Arthritis Clinic in 2005, where 11 providers, including a disability and chronic illness counselor, and a naturopathic registered dietitian currently work. And he would love to have you join Team Overman to ride down the Oregon coast with him this September in support of the Arthritis Foundation. Disclaimer, the medical information in this webinar is provided for educational purposes only and is not to be used or relied on for any diagnostic or treatment purposes. This should not be used as a substitute for professional diagnosis or treatment. Please feel free to submit any questions you might have during this webinar by using the Send a Question button on your screen. Joy and Steve will answer any questions at the end of the presentation as time permits. The presentation recording, as well as answers to any questions that are not addressed during the webinar, will be posted on our website. And now, I'd like to turn it over to Joy and Steve.
Thank you so much. Can we advance the slide, please? So I would just like to tell all of you kind people that have called in a little bit about my story, and then Steve's going to talk to you a little bit about his own. I think I'm probably like a lot of you in that I have multiple conditions and they overlap, and it took me many, many years to find answers to what was wrong with me and a few more years to find adequate treatment. I've been in and out of a lot of doctors' offices, some that I had to fire, some that I enjoyed helping me find other wonderful doctors like them. I did find my way to some recovery with interventions and surgery and alternative treatments. My philosophy was pretty much try everything. And I think also just time helped, changing my lifestyle, reducing the stress in my life, getting more rest, all those factors helped as well. So as you learned at the introduction, I've recovered enough to work part-time after 20 years out of the labor market, and I just consider that a tremendous gift. But I would close by saying, had I not recovered well enough to work, I had found a very happy and meaningful life with illness and had accepted that I would never get well, and felt that I was living a really quality life that embraced and included my illness. So that's the hope that I would like to share with you primarily. So with that, I'll turn it over to my good friend and physician, Dr. Selak and Overman.
Thanks, Joy. Yes, in advancing the next slide for all those of you who are looking on, just add 15 years to that picture and you will see me now. That's what that was the picture when we started the book together, and I'm headed for retirement and haven't gotten it updated, so add a little bit of gray hair. Really, the only thing I'd like to say in way of introduction is I'm a rheumatologist. I'm not a urologist. And rheumatology as the subspecialty in both pediatrics and internal medicine that sees all types of complex diseases with pain and inflammation and lots of interaction. And so I'll give you my perspective based on both rheumatologic conditions as well as having, cared for patients like Joy who also had interstitial cystitis and other illnesses. I think the only other thing I'd like to say in way of background is that I'm excited about my retirement in that I'm not a golfer, and really what my passion is and will be is to do more type of work like this, which is really to talk about the crucial element in healthcare of the doctor-patient relationship and communication. In medical school, we're taught, this is many years ago for me, but we're taught that 90% of the diagnosis is in the story, is in the history. And yet there are so many things that are getting in the way of the telling of that story. And so my future, I hope, holds some opportunities to focus on doctor-patient communication, patient advocacy, because I think that's really where healthcare reform and change will occur to improve quality and control costs. But let's have some fun this afternoon.
Okay, let's take the next slide. Now you're seeing the title of our book, and we'll tell you a little bit about how we came to write the book. I found Dr. Overman many years into my illness journey, but with the IC diagnosis, but with the awareness that there was more going on with me than the IC, and I found my way to him, and we just began to work together, and my condition began to stabilize a bit. And as we got to know each other better, we typically ended up spending the last few moments of our meetings talking about illness in general. And I remember saying to him, I'm still sick, but I don't feel the same way about being sick, having worked with you for a year or so. So we came to understand that chronic illness is not static, that there's phases and stages and lessons to learn and tactics and strategies that are unique to each phase. And we decided that maybe if we could zero in on that and work together on a book that came from both the doctor and the patient relationship, that it might really help doctors and patients out there to find their way to better care and better management of their illness. Steve, you want to add to that? Maybe the grief and
the only thing I would add to what I remember is Joy coming into the office, and she said, "Would you like to write a book with me?" And I'm sort of in that camp that says yes to everything, but when she came back several months later and said, "Let's get started," that I was totally surprised and blown away. But the part that I remember, Joy, was also once you had this sense that you wanted to write a book, you went to the bookstore and you looked through many, many books. And certainly I've heard this on the doctor's side, where patients go they turn to their neighbors, they turn to a book, and they look for the answers. And there's always, if you do blank, and an individual can fill in that blank. If you exercise, if you eat differently, if you get your spiritual life in order, if you do whatever it is, that will be the cure for the illness. And I think that's what so activated me in wanting to write with you, because yours was a different approach, which was, let me just tell my stories about what it is to have illness, and then let's see if we can create a dialogue. And that's the part that I found most rewarding, which was to read your stories and then to say, okay, I see this journey, and then that's what we ended up really talking about.
Exactly. One of the things we did very early on was sat down with a bunch of index cards, and we wrote down, or at least I was writing down, maybe Steve was just coaching me from the sidelines to see if I was coming up with things that were typical to other patients, but writing down stories, experiences that we felt maybe a lot of people with chronic conditions faced. And we began to batch them, put them into batches, and say, well, these stories kind of fit together, and these stories kind of fit together. And as we looked at them, we could see that they also flowed through time. So not only did they cluster around a phase or a stage of the illness, but they moved that this comes first and this comes second. So we came up with in the first book 3 phases to the illness journey, and in the second book we added a 4th one. So what we call them is getting sick, being sick, grief and acceptance, and living well.
Let's go to the next slide.
Yeah. Steve, you want to talk a little bit more about the phases?
Sure. I just, moving on to those, I just want to make sure that the audience was seeing that which you were describing. I guess the only thing I would comment right now is one sees these phases. There's others that have written about this from an academic perspective. I think the concepts are the getting sick phase is when a person's looking for diagnosis. Crisis is a common descriptor. As I have thought about these phases, it's helped me as a physician to try to understand what it is that the patients need. And I think in the crisis phase, if there's ever a time that a doctor might put on their white coat and try to be reassuring and to create the sense of hope, that's really the time. And I distinguish that only from the second phase, being sick, where many times patients have a sense and they're on treatment and they're getting better. And this is where I think that the coaching element of being a physician particularly comes in. It really is more of a give and take, though it's pretty clear it's not just a partnership, because the performer, it's the patient that's trying to get better. In our first book, as you mentioned, Joy, we didn't have grief and acceptance because it was peppered throughout. And in fact, grief and acceptance is throughout illness. It recurs over and over again. But I think we pulled it out because there is this common phase, at least that I've seen and sensed, when I've had patients where we've made diagnoses, we've started treatment, they do absolutely as you did. You just did everything correctly in trying to take care of yourself and oneself, and then comes that moment when, in fact, the disease didn't go away, the illness didn't go away. And that's the first real grief episode. It's some have described it as the death of self, the death of the person that you were or the way you wanted to be. And trying to get through that first episode of grief is really quite dramatic. And what it allows, though, when one can, then is to move to the living well, not defined by the illness, but in fact managing illness and finding the meaning of the new and different life that you've so nicely articulated.
Right.
Take it, Joy.
And I would reiterate that on the grief and acceptance that you can't move to the living well phase, in my opinion, until you've been taken to your knees and let those emotions come out that are attached to the realization that you are not ever going to be the person that you once were. And even if you do get well, you will not be the person that you once were. So it is a very, very important, very sad time. I always get choked up when I even remember it or try to talk about it, but it's essential, and it is the thing that leads you to an ability to build a new life that has meaning and that contains illness. And I would also
Joy,
just go back. Yeah.
No, go ahead.
Go
Go
ahead.
ahead.
I would
I'm
just
just
go
going to
back
ask
to you go. You go.
I was just going to ask you about that. Did you go through that often? That sense of grief, was that a recurring experience?
Absolutely. I mean, the first time, I think the first time probably is when the word chronic has meaning, that you as a patient accept that chronic means I can get all the great doctors in the world and all the great treatment in the world, but at this moment, there's no known cure for what I have. So it's called chronic, and that means it stays with me. So just accepting the definition of the word is probably the first big one. But in my case, when I was diagnosed, after being diagnosed with fibromyalgia and IC and mixed connective tissue disease, then several years later to come down with a neurological condition, trigeminal neuralgia, which is very painful. That just took me to my knees for a long time. It just seemed, how could this possibly be that there has to be a fourth one that I have to learn to live with and treat and find the right doctors? And so that was hard, but it all led to living well. So, Steve, you want to talk about what it means to be?
Let's move on to the next slide.
Yeah.
Yeah, and just acknowledge for those in the audience, I really don't like reading slides, but let's read this together just to acknowledge where many individuals share a common experience, that a chronic illness means that it has some chronicity in terms of months and has some of these characteristics, that the causes are poorly understood or completely unknown, that there are no known cures or it wouldn't become chronic, and that the therapies can be directed in different ways, sometimes attempting to control the underlying pathophysiology as best we understand it, which is never complete, or just trying to control symptoms. At the same time, symptoms may be persistent. They may be recurring, or there's some people with chronic illness where, in fact, they don't have symptoms to tip them off as to what's going on. And then last but not least on this slide is that, in fact, remissions may come, they may come and go, they may be unpredictable, and they may be only temporary. So it's that sense of such unknown that is is the thread that weaves through all of these. Having made some comments about definition, I would like to bring it back to IC. It's just an absolutely wonderful website, and I went back and looked at it. And in the under the diagnosis area, individuals with IC, like you, Joy, have many associated conditions. And in fact, the ones that are noted on the website, I'll just read from the website, is allergies and sensitivities, celiac, chronic fatigue syndrome, chronic prostatitis, endometriosis, fibromyalgia, irritable bowel syndrome, lupus, pelvic floor dysfunction, pudendal nerve neuralgia, Sjogren's syndrome, and vulvodynia. And I list those only to bring it back to a rheumatologic perspective and try to help answer some of the questions that have already been asked and that are out there, which is how do we describe pain? How do we interpret pain? It's so difficult. Is there a better way? And when one asks, is there a better way, I imagine, for example, in one of our questionnaires, we have pain 0 to 10. Well, is 0 to 10 really describe pain? I don't think so. And I think what I will do right now, that we'll come back to it later, is to try to provide a framework around which to try to understand both IC, I believe, though as I've already said, I'm not the expert, but some of my chronic pain conditions, such as fibromyalgia, that there's always, and I say always, different elements to pain that exist in every person. And I'll break them into 3 parts, and I'll give a very short little metaphor for it. The 3 parts, I speak in terms of my record player with old vinyl in the living room. For every pain symptom, we hope that we think of it as a scratch in the record, and this scratch is this noise that we want to get rid of. It's called pain. We hope that it's a fuzzball that we can flick off and have it go away, but in fact we can't. And sometimes when we're really working hard at trying to do that, we can even make it worse by scratching the record further. That's what's called nociception. It comes from wherever the tissue is. That's a signal that goes up into the body. But for every time there's a signal from the bladder, for example, an injury, a sensitivity, that signal must go through the nervous system. And in the record player metaphor, that is the wires to the amplifier to the speakers. And there's always a volume control. And so that sensitivity can go up and down. And that's totally separate. That's different from the underlying injury or primary sensation. Then with those 2 parts, I might walk into my living room, listen to a record with a scratch on it, and when it's one of my old, Peter, Paul and Mary or James Taylor, and I hear the scratch, in fact, I don't hear the scratch. All I do is hear the music, and I think, boy, isn't that wonderful music, and I'm able to tune out the scratch because that scratch has no meaning. On the other hand, brand new record that I walk in the next day and listen to it, that scratch is all I can hear because the scratch makes me unhappy or it has meaning. I'm angry at the person who caused the scratch. So every person with pain, and that includes IC to fibromyalgia to my other conditions I care for, have these 3 components that always need to be thought of, both what's causing the irritation in the bladder, the pelvic region, how does that transmit through our nervous system, and what do we do to try to calm that, and then how do we find meaning in life and listen to life's music as opposed to pain as the primary issue of the moment. So why don't we move on to the next slide.
Right, and this is relevant here because I noticed the questions that we've seen that came in before the webcast often had to do with my doctor doesn't listen to me, or my doctor doesn't seem to be able to find a solution, or doesn't understand my pain, doesn't want to treat my pain, the pain treatment I'm being offered doesn't work. And of course, we all go through this. And I think for me, the way I got out of that maze was really understanding that the responsibility for hiring the right doctor for me and firing the wrong doctors for me, which doesn't necessarily mean they're bad doctors, just not the right doctor for me, is on me. And so how do you become a patient that has some skills in determining if you're with the right person. And one of the things I learned, and it was with a urologist, the first doctor that I left was a urologist, and he offered me one treatment. He diagnosed the IC, he offered me one treatment. When I got side effects from the treatment, he said, my other patients don't have those side effects, and that was a strike. He was 45 minutes late for every appointment. That was a strike. That was disrespectful to me and my time. And thirdly, he, what was the other one? He said one time when I asked him a question and gave me an answer, and I said, well, how do you know? And he said, because I'm the doctor. That's how I know. And that was strike 3. Added to that, the fact that I wasn't going to be able to build a partnership with this person. Added to that was the fact that I looked around his waiting room, and it was all elderly men, and he talked to me about their treatment. And I didn't see any women, and I see primarily is effective, women get IC. So I thought, this guy's a urologist, but that doesn't mean he's my urologist for my urological condition. So I went out and began to ask around to other doctors I knew, to nurses. Now you have patient support organizations online that can be incredibly helpful in helping you. And I did find my way to 2 women, excellent urologists. They were writing and doing research on IC at a university teaching hospital, and I landed in the right place. But in order to find them, I had to take the responsibility to let this other man go. And I had a great story. I was speaking to a patient group one day, and I told this story about you have to be willing to fire the doctor and find the right one. And at the end of the meeting, a physician came up to me who was sort of a supporting physician for the group, and she said, I'm really glad you said that, because I can't fire the patient. Sometimes I know I'm not the right one. Sometimes it's just a personality thing, or sometimes I don't have the skill basket, but I can't fire the patient. The patient has to fire me. And so just because you look further doesn't mean it's a bad doctor. It doesn't mean you quit. It doesn't mean you're doctor shopping. It just means you're looking for the right fit. You want to add anything?
All I would add, what I would add, though, to be acknowledging that while there's many things the patient can do, needs to do, as you just described, Joy, still the physician, the provider is the professional. And there is certainly increasing amounts of education and activities in trying to help doctors do a better job in that which you want. Up in our local area here a few years ago, there was a course on compassion that I assisted with. And, that's pretty remarkable that now that was a CME course. This is not for medical students, but this is for physicians in practice. So there's things that, doctors need to really work on their own self-work, so to speak, in order to be present, and there's more acknowledgement of that. At the same time, I invite patients to be aware and supportive because, as most know, electronic medical records, concern about costs, regulatory systems, and so forth certainly have created an awful lot of background noise that interferes both with the patient and physician experience.
Okay, next slide. This one, to me, I think Steve and I reacted to this slide differently. This is a cartoon by one of his patients, Alice Gray, which we're so appreciative of her for letting us share that. And here's a patient giving, a litany of symptoms to the doctor. And one of the things that I felt and I learned was to be quite careful, agreeing on clear language to describe symptoms, keeping your questions to the time allowed, and being really prepared for the meeting so you don't spend a lot of time trying to remember what meds you're on or trying to remember what year your symptoms arrived. So the doctor feeling like perhaps he's getting too much information, I think the patient can help that by being as professional and as organized as you want your doctor to be.
And I certainly didn't disagree with that, Joy, but my response was that this was not too much information. It's just that it was presented in not the optimal way, that we're all trying to look for patterns. We're trying to look for diagnosis and understanding. And what I will say to a patient to try to make the point is, I may not, in fact, I don't have time to watch you paint a picture, one stroke at a time, trying to see it develop with time. But if you bring that picture in, developed on one piece of paper with symptoms, with questions, with your own thoughts, your own diagnosis, and I can glance at it in one glance, I can see a pattern that gives me tremendous insight that I may not get when you just feed them to me one at a time. And we'll come back to that in some of our forms.
Right. And I'd add to that, the patients often feel frustrated that their doctors can't hit the bullseye on the first try in terms of treating their pain. And there was a question that came in before the webinar about it's difficult to describe the many types of pain that are occurring. It makes it difficult to realize which meds are helping, which symptoms. Is there an easier way to evaluate pain symptoms? And I do think part of the being sick, the second phase, you have a diagnosis, now you're trying to bring control to your life and stabilize your conditions. It is going to be trial and error. You're going to have to try different medications. You're going to have to try different doses, different combinations. You're going to need to look at alternative therapies, lifestyle changes. So it isn't typically going to be that you walk in, you describe your symptoms, the doctor says, here, take this, and that's it. It's complicated. And so patience and adequate information and organization are required on both sides.
Yes, Joy, and in fact, one of the questions did ask, I find it difficult to describe the many types of pain. And I will just underline the single thing that I think is most important. There's many ways that we could discuss this, but still, when a person thinks of a symptom, a type of pain, and tries to present this pain comes on in these circumstances, triggered by these events or these associations, and seems to go away with these particular factors or is modulated by things. It's what makes it come on and what makes it go away. And how that pattern is with one type of pain versus another type of pain is really way more important to your physician than it's 0 to 10 or it feels like. It's really the onset and offset that gives us the most insight.
Mm-hmm. And equally, after trying a medication and going back, reporting on all those same things about the medication.
Absolutely. And that's
the side effects, how quickly did it kick in, what did it help and what did it not help. So that can help your physician know, is this joint and muscle, is this neurological, is this, whatever.
Right.
Okay. Oh, there's
slide.
Hi, Steve. You need to help everybody get out of the ditch here, Steve.
All right. So let's see. Next slide. Maybe my computer's, no, there we go. I will frame this for the audience in two ways. One is to say this story that I'll try to be brief about is really what got our initial book published. And this was, 15 years ago. I was sitting with an expert researcher, John Russell, in the area of fibromyalgia. And I said, John, here's my perception of what really is happening. And at the end, being the academic that he was, he says, is that published? I'd like to reference that. And I said, no, but you could help us. And so that was the beginning of a wonderful journey for us. What it was that I said is that many people come in I will just ask, do you feel stuck? And or have other physicians or friends or family suggested that if you only tried harder, that you'd get better? And so many times that hits home, this sense of not being able to figure out how to get better, but trying harder and harder and then being invalidated with statements like that is a very, very common way that some people come in. And so that sense of being stuck, I try to use a metaphor. So if you've been cruising along and something happens, whatever that is that in fact puts you off into the ditch, and you continue to get out of the ditch in the same way that you've always driven in life, that's usually pushing harder on the accelerator. The problem is you've never been in the ditch before. So here you are pushing harder and harder, wanting to get better and better, But without even knowing it, what's happening is the tires are spinning. And as they spin, you can get more and more stuck. Now, this is the illness. We haven't figured it out. We don't have the right diagnosis. And at the same time, you're trying harder and harder. And what happens is, sooner or later, if you look at the dashboard, the engine either runs out of gas. That's when you go dead in the ditch. That's when you're so depressed you really can't leave the house. Or you run out of you run out of oil or water first. That's when the engine starts to overheat. And that's my metaphor for what happens to the nervous system. As I mentioned pain before, there's the scratch part. There's the part that's why are you stuck? What's going on under the car? But this secondary phenomenon occurs, which is the engine can overheat. And that's what I allude to the nervous system. And in fibromyalgia, the entire nervous system seems to be hypersensitive. So, how do we get out of this situation? I say I'm not AAA. 3 things have to happen. I have to stand, crawl on my hands and knees and try to look harder for what's underneath the car. Why are you stuck? What are the inflammatory illnesses that we're missing? But at the same time, if we don't get water or oil into the engine and get it cooled down, if we don't get the nervous system calmed down, then we also won't control pain. But right at the center is how you're driving the car. If you can't gain this understanding that something about pushing too hard and the way you've been doing things has been counterproductive, there's an element then of the self. And so trying to, acknowledge that experience, I think, gets us going.
And I'd add to that, I think that this driving off the road is exacerbated and complicated by the fact that we tend to use war terms in describing how we cope with illness in America. We fight cancer. We battle disease. We're going to win. We're not going to let it get me down. We're not going to let it beat me. And when I've spoken to patient groups, I often hear that with real pride, patients that are really suffering saying, but I'm going to fight. I'm not going to let it get to me. I'm not going to let it beat me. Well, that doesn't work. I mean, you need to get to know it, get to know the illness, make peace with it, absorb it into your life, see who you are with it. And that is a way out of the ditch, but it's a very different thinking process than we typically apply to how to cope with illness in America.
And sometimes we just don't want to do that. That's, the next cartoon. There's the other phase of is not explaining, I've got all these symptoms, but that's the person who doesn't either want to come in at all or comes in and just says, I'm just kind of the way I am and doesn't have much to say.
Right, and
so
also
let's go
people
ahead.
Just to add to that, also people who I only will go to alternative practitioners, I will only go to Western practitioners, I will only take pills, I will not do acupuncture. This deciding without any experimentation or experience and research that you are only going to deal with your illness in one particular way. And with complex overlapping conditions like most IC patients have, that probably isn't going to serve you well.
So what do we do about this? I think our next slide, if we can advance that, has some ideas. So Joy, why don't you take sort of your perspective first, and I'll run down mine.
Okay. So we're calling this the toolkit. We've spoken to this just a little bit, but I still to this day, even though I'm better, try to practice these policies when I'm working with my physician. So one is as not to be distracted, be fully present for the meeting so your phone's not on, you're not interrupting. The second one is if you need a longer meeting, if you can't see the nurse practitioner, you need to see the treating physician, you need to ask for that. You need to make clear what it is you need. And I have found that, generally speaking, that's not been a problem when I clearly state what I need and why I get the longer appointment or I get the records sent out. I also prepare a meeting list, and I do this with a copy for me and a copy for my physician. It's a template that I keep on my computer. Every time I have a doctor's appointment, I just update it So it's all my diagnoses first, and about the time I receive those diagnoses, the year, the medicines I'm currently taking and the supplements and the doses, any changes to my symptoms, and this goes back to what Steve said before, really trying to find what you want to tell the physician is what are the triggers, what are the, what brings this on. In my case, rapid drops in barometric pressure still is the main trigger for me for symptoms. IC as well as trigeminal neuralgia. Barometric pressure changes is just a big one. Fatigue and stress are big ones. Vibration from a car or an airplane. So that can help the doctor. And then finally, try to come up with three, if it's a normal length of appointment, 3 questions and what your goals are. So that way, if you zero in on the 3 things you most need to talk about in this meeting, knowing you'll be back again, it saves time, it respects the doctor's time, it focuses the meeting and can be really helpful. And the nurses, I find, appreciate this. Typically, they'll use my report to update my file, and then they put it in the file. And it's there as a record. And then finally, I don't have to do this now because I'm more stable, but I, for many, many years, offered an annual report to my physicians. So all my treating physicians, their contact information, specialty, all the innovations I had tried, we had tried for that entire year, the effects and outcomes of those, any allergies, changes, or improvements in my health over that year. And it was just a summary, 2-page maybe summary report. And this went out to every treating physician. Very often for the next 6 months when I came to an appointment, my doctor would be giving a quick read to the annual report. And all of them let me know how helpful it was to them to just have that tight summary and include the other doctors I was seeing and the other treatments I was receiving. And then, of course, say thank you.
And in fact, my list, I'll go fairly quickly because it just parallels Joy's, which she initiated on her own. But I think probably the most important thing that I say almost every visit when I sit down and the computer's there and I may get a list and a glance at that, but it's really leaning back and trying to connect, smile, and say, you know, what is on your agenda today, or how can I help you, in a very serious way to try to get a quick summary frame of what's going on, because even when the list is complete and there's a number of questions and medications have been changed, it may be something clear out of left field, that a spouse just left or they just lost their job. And that really is important because that takes it out of a coaching, how are we going to move ahead together, to, wait a minute, we're in crisis for a whole different set of reasons, and we need to think about it from a different perspective. The other things, I won't go through line by line here, but they're just ways of writing things down. We give every patient in our office a form. They get tired of filling it out, but it asks about function, global well-being, pain, and so forth. It helps us both document as well as understand. And then I try to get patients to do the types of summaries that Joy just described to give to me, and then ultimately put it in a chart and have it and carry forward. And I would also say that each one of these forms that Joy mentioned, my guess is, and I would encourage every patient to give it to every doctor they see so that each doctor can see the whole you. Don't divvy it up into, I'm only talking my bladder today and my shoulder tomorrow and my back the next day. Every doctor needs to kind of understand what's going on within you as a whole person.
Exactly. Right. Yeah.
Next slide.
Okay, now we're getting into the fun part. And I have some stories I can share with you around my top 10 list for living well even while sick. And Steve, I know, has patient stories in these areas too. So just run through them really quickly. Take care of yourself first. I think particularly women, and women have a higher incidence of IC, are brought up to think about the other, to take care of our children, to defer our needs to other people's needs. And when you've got chronic illness, you just have to learn to be able to say, no, I can't do that today, or I really need to go rest now, or I'm sorry, honey, I can't go to that party. You need to put yourself first because that's how you're going to stabilize and balance your condition in your life. Having said that, you never, never, never give up. I went through denied a disability claim, 3 years fighting with the insurance company to try to get my claim paid. And it was clear to me as we went through those long battles and getting records and sending in more records and more proof that the tactic was to wear me down and that eventually I would give up. And that was the plan. So once I finally earned that disability claim, although that was one of my moments of grief and acceptance, I wanted it to happen, and then when I finally did, it just made me so sad. But it taught me not to give up. It taught me things could happen if I just kept trying. I think sometimes we pretend we're okay when we're not, or maybe we exaggerate how bad we're feeling when we're feeling neglected or not getting enough sympathy. And the more we can just be honest, straightforward, even unemotional. I think if someone needs to know about your illness, if you can tell it to them, tell them your story in the most straightforward, honest, simple way possible, not ashamed, not making up excuses, not asking for sympathy, just here it is. That generally that is accepted with a positive attitude. Enrolling in the School of Whatever Works goes back a little bit to what we said earlier, that there's all kinds of alternative therapies, lifestyle changes, psychological improvements we could all make. It's besides the Western medicine. So look at everything. Fatigue is such a common companion of pain, and if you can make friends with it instead of fight it, it helps. My one strategy I learned 20 years ago and still do to this day is I take a rest period every single day for at least an hour in bed, quiet. And it really helps the tank get filled up. And I don't resist that. I've come to enjoy it, and I feel like I'm lucky. Steve, you want to talk about any of these? I feel like I'm talking too much here.
Well, you're not, but I'll just, the perspective I have is I've just been so lucky to have so many patients teach me how to to navigate their top 10, so to speak. The 3 areas I'll just mention is I just think of different patients. One is to try to help people and each of us find our creative selves and express that. So Alice, who offered these cartoons for us, she's got such complexity, and I so respect how she navigates all this complexity, and she finds ways to express it in her art. And Joy, you did that in your acting and working in theaters. The second is just the caring part of each of us and how that can be expressed. I know I have one woman, she was young when I first met her. She came out of the juvenile arthritis clinic, and she interviewed rheumatologists. Now that I'm retiring, this has been 35 years I've known her. And Susan, on more than one occasion, came in and basically gave me the greatest gift a doctor can have, is to have a patient who's willing to come back and say, you didn't do very well last time. You're not doing this or that, or I need this or that. And I think the elements of life, which is to be able to go in and say, forgive me, which I've said many times, I forgive and thank you, are really remarkable. And those who feel insecure about being direct with a physician, try it sometime. I can tell you, if your physician isn't totally appreciative of your willingness to say these things or express your feelings, then you do need a new physician, because we get such, we learn so much when people really tell us what they've experienced. And the last area is just, finding the new you that you found. Joy, you found new work, new avocation, new passions. I've had a number of patients who have gone back and gotten their degrees, even while still ill, in psychology, and now run pain groups and stuff like that. And it's just a remarkable journey to see how people take that which they've been dealt and still use it to fuel their fire to move ahead.
Right. I think that finding a way to share your gifts, which is what you're speaking to there, is so helpful. And first of all, let me tee that up by saying this doesn't happen in the early years of coping with a newly diagnosed chronic condition. It's a full-time job just to figure out what's wrong and what to do about it. But when you get to the point where you're still symptomatic, you're still sick, but you have more stability and you've accepted the diagnosis as chronic, then looking around and saying, okay, I can't be who I was. I can't be, in my case, a stockbroker anymore. What can I do? Who can I be within the boundaries that I need to live in now? And in my case, I was able to engage in some nonprofit work and became a volunteer on my own time, according to my own schedule, eventually joined a board or two and became a founder of a nonprofit, and led ultimately to the job I have now, which is in arts education. So that all came from being willing to stop being that aggressive professional 9-to-5 person and finding pathways that I could enter within the boundaries of my illness and still maintain my stability. And I also just want to say on the search for silver linings, there are silver linings to illness, and one that I certainly learned was finding the incredible generosity and sensitivity of my husband and his support for me in these times that I don't think I would have known had it not been asked of him. As long as I was a healthy go-getter, he didn't need to offer me that. And just seeing that side of him and recognizing what was there for me was a tremendous blessing. And so there are silver linings, I think, if you look for them.
Joy, I so appreciate what you say. Let's move to the last slide and let people sort of just kind of think of that with your comments and invite questions. There may be some more that have come in. And I'm not sure how that
we have
happened.
a couple of questions.
Yes.
Okay. The first one is, most people with IC have seen many urologists who seem to know little or nothing about IC or how to treat it. I heard of one doctor who told his patients that IC doesn't exist. Some are unwilling to refer patients to the appropriate specialist. What can be done to rectify the situation and educate these doctors?
Let me take that on first.
Okay.
Oh, I'm sorry. Boy, I tell you, the waves are back and forth slow. But anyway, I'm going to start first from the physician's perspective and just say that I think that I don't know that we can, quote, educate physicians any differently. I think, as you said already, Joy, it's finding the physician that you can work with. It is each patient's opportunity to educate physicians and to educate themselves. So as we've already laid out, IC, like many of my conditions I care for, like fibromyalgia, is not a simple it. There's many different parts to it in terms of pain, inflammation, different kinds of therapies, and so forth. So I think it does become part of the patient's journey to find a doctor who's willing to think broadly. And those who say things like, I don't believe in it, that's just their way of trying to get you out of the office, thank them kindly, and just leave and find somebody who you can work with.
Right. And I also think there were some questions about being referred and not wanting to refer. You need a good internal medicine practitioner. And if you have that kind of a person whose job it is to identify and refer you according to your symptoms or according to your diagnosis, that can be quite helpful. And very often, if you're really happy with your internist, then you will also be happy with the people that internist refers you to, because they all work together and they refer to each other and they help each other solve problems. So I call that the Good Doctor Club. If you can find one really wonderful practitioner, especially in internal medicine, but in other specialties, often that puts you in a referral group where you will find more doctors, and that certainly was the case working with Steve and with Dr. Overman in Seattle, and it's been the same here in Austin, Texas, where I live now.
Okay, thank you. We have another question. Oh, sorry. The next question is, what is the best approach to ask for pain medication when it seems like doctors don't want to prescribe it?
Joy, I'll start with this again. There's several questions around pain medicines, including there was another question, I believe, about emergency room visits and pain. And I guess my advice again is for where pain is the issue, and we have, it's very complex, and the more well-read that you as a patient can be about the elements of pain that I've tried to describe and begin to understand within oneself the different pieces of the puzzle, the better able you will be to have a conversation with your physician. For example, I don't think, or I'll say it this way, any patient of mine who has chronic pain, such as fibromyalgia, who ends up in the emergency room for pain is a failed practice on my part. I have failed them. If they end up in the emergency room, it should be to look for a diagnosis that we've missed or something happened intercurrently. But if it's for pain of the chronic nature, then my job should have been to help them understand how to deal with pain on a regular basis and then how to treat flares, and then to have a way for them to contact me or the person on call when our initial flare management doesn't work, because we might need to think about it differently. So it's the same conversation around narcotics. Sometimes people need to use narcotics intermittently, but other times I will try to encourage people to think of it like a fire, that if you see a flame starting in some brush, sometimes you have to hit it earlier, harder, in order to keep pain from becoming expansive. Sometimes it does take regular medicine. So it is a conversation that has been made more difficult in our society because of all the stigma around narcotics. And so I just encourage each patient to do their own reading, to learn about about pain management and the different components. So when you sit down and talk to your physician, they understand that you really are not, quote, drug seeking. You're looking for controlled pain in the different modalities, from narcotics to non-narcotics to things you do, and to improve your function.
And I think also because there is, especially around opiate medication, so much concern about addiction, just to be very transparent and honest and responsible with your doctors, with the agreement you make with your doctor about the use of pain medication, so that you're reporting very accurately when you're taking the medication, why you're taking it, how effective it was, is the dose working or not working. It's all part of building trust, and that is a two-way street.
Okay, next question? Yes. Why is it so common that doctors eventually jump to the conclusion that pain is all in our heads?
I'll take that again. I can't speak for all doctors. I will make the simple statement that all pain is in our heads. But for our heads, we would not have pain. So it's by acknowledging the three parts that I tried to touch on earlier, that there's almost always some trigger out in the tissue. So in this setting, we're going to say the bladder. You know, the bladder may have become sensitized from a chemical, from something you ate. There may be something, there's clearly something about the bladder mucosa in the bladder that is maybe like the bowel, which I know a little bit more about, even though I'm a rheumatologist. Or it could be like a tendon insertion where there's inflammation that comes and goes. There are local events that trigger pain and trigger inflammation. At the same time, that sensation goes through the nervous system, and how that nervous system modulates is really an important part of our consideration. For those who've heard of shingles, shingles is a viral inflammation of a nerve that comes and goes. The virus and inflammation goes away, but in some people, a minority, but an important minority, they may have pain in that nerve, Joy, like your trigeminal neuralgia, but it's a parallel. That nerve can be painful for a long time, if not a lifetime. And the answer as to why after inflammation, after injury to that nerve, that pain continues, the medical establishment answer is, we don't know. We don't understand why some nerves become hypersensitive like that. And then, of course, there's the third part, which is if you've got that amount of pain of different types, nerve and local injury type inflammation pain, and it depends on how it impacts your life. That when this impacts, I mean, Joy, you had a supportive relationship. I've seen this type of illness and pain drive wedges into relationships, and then that only adds that much more emotional and real-world content to it. And so all these need to be acknowledged, appreciated, not pigeonholed, and each one needs to be considered and dealt with individually and in parallel. So I always say that we need to be working on each of these areas simultaneously.
Right, and I'd add that, if someone is saying to you, your pain is all in your head, and leaving it at that and dismissing you, that's a strike, probably 3 all at the same time. So that's a fireable offense. And B, I think if you can get language around how you experience your pain, what triggers it, how it progresses. For example, with my IC, I have pain in the bladder. It goes right into out the nerves of my bladder, into my sacrum, up my back, out of my arms, and then I hurt all over. I experience it that way. When I was able to describe that, then we were clearly beginning to look at both the bladder and the pain there, as well as the central nervous system, to where that pain was being delivered. And we were able to look at treatments appropriate for my reporting. So I think that's another part of it there's so many websites and so much information on the internet now that you can look at to help find language and words that accurately describe pain, that perhaps that helps to address it as well. It's back to what Steve said, it's the story.
Okay. Well, our time has come to an end. I just want to remind folks that our presentation recording, as well as answers to the questions that were asked, the ones that Steve and Joy did not get to, will be posted on our website. I want to thank Joy and Steve for their time and for sharing their experience with us all. I want to invite viewers to complete a survey on this webinar. The link for the survey is located under the attachment section of the webinar and will also be sent to you via email. Your feedback is important to us. Thank you for joining us.
Thank you.
Thank you. So are we off?